Okay, I'm Dr. Bishop, your instructor for the course Abnormal Psychology, and I thought I would make a sort of introductory presentation on some basic concepts and terms, and in particular I'm going to focus on the definition of abnormality, the use of the Diagnostic and Statistical manual, which is psychiatrists use to classify disorders, and some other basic terminology and concepts which are important to get under your belt. So the first slide here is the categories of Diagnostic and Statistical Manual disorders. These are the broad categories, and some of them you'll recognize. For example, bipolar disorders and depressive disorders, anxiety disorders, obsessive-compulsive disorders, trauma, stress disorder, post-traumatic stress disorder, and a variety of others. Here's some on sexual dysfunctions, neurocognitive disorders, includes things like Alzheimer's and Parkinson's, personality disorders such as antisocial personality disorder, paranoid personality disorder. And here's another sexuality. This is deviant sexualities, paraphilias like pedophilia or voyeurism or exhibitionism or other atypical sexual disorders that cause problems. So the DSM again stands for Diagnostic and Statistical Manual of Mental Disorders. It is in fact the predominant psychiatric classification system in the United States. It has many versions. It has undergone multiple revisions, and it keeps trying to get better to increase reliability and validity. And the current version is referred to as DSM-5. The DSM-5 provides specific criteria for diagnosing each of the recognized psychological disorders. For example, panic disorder, major depressive disorder, and so forth. So for each of these disorders, it presents information on the course of the disorder, how it would go if it were untreated, and you looked at its development over time. Prevalence is a term referring to how common the disorder is, and we'll talk a little more about that later. Symptoms for each diagnosis are clearly listed in the DSM. Each category, each specific disorder indicates the number of symptoms necessary to receive a diagnosis. It also includes a specific inclusion or exclusion criteria. Inclusion means it has to be there, or it's a symptom that contributes to the definition of the disorder. Exclusion criteria has to do with various conditions that, even though some of the other criteria are present, would exclude a diagnosis. A good example would be depression, otherwise known as bereavement, for the loss of a relative or a spouse or a child. Empirically grounded indicates that the DSM has been trying to make its diagnoses and categories based on scientific and empirically grounded information. The disorders are organized in the chapters based on shared etiology. Etiology, a term meaning causation. So the shared, for example, stress and trauma share often some trauma as an etiology. Comorbidity is a term that indicates that certain disorders tend to co-occur, occur at the same time. They overlap. For example, anxiety and depression. Almost always, well, 50% of the time, if you have one, you have the other. So they are comorbid. Some other facts about the DSM. First of all, it's real important to recognize it's only a descriptive manual. It does not include information about causes or treatments. And also, it's a categorical system as opposed to a dimensional system. So either you have the disorder or you don't. So you can have, for example, no symptoms or a few symptoms, or symptoms almost enough to meet the criteria for the disorder, and therefore but you don't quite get the label. You don't get classified. Then you can have people who meet the criteria, for example, Aaron, just over the criteria, or you can have somebody that's severely disabled, for example, Max, many and severe symptoms. So there are other classification systems, in particular the ICD-10, which is an alternative system. It's a medical book, and it includes both general medical and psychological disorders. It's used in other parts of the world, although U.S. is thinking about going to the ICD-10. Additional information about the DSM. First of all, it's published by the American Psychiatric Association, the groups that created the diagnostic categories and oversee them and create the specific criteria are mostly psychiatrists. It's a text that's published by the American Psychiatric Association, and so it doesn't really include many psychologists, although there are some on the committees to develop criteria for specific disorders. It clearly is not a static document. It continues to get revised. New disorders can be listed with each revision, and some are dropped. For example, in 1973, the category of homosexuality was dropped. So it was a mental disorder in 72, but not in 74. The criteria for diagnosis may also change. For example, in the latest version, bereavement can be diagnosed as a mental disorder, whereas it could not in DSM-4. So it's a work in progress. In terms, now this is a DSM-4 text revision definition of mental disorders, but it gets at the basic issue of how to define a disorder according to the DSM. It overlaps your textbook pretty closely. Essentially, the top part here, the defining characteristics, are the inclusion characteristics. Generally, you have a behavioral or psychological syndrome. Syndrome is a group of associated features, for example, loss of interest in things you normally are interested in, depressed mood, sleep disturbance are a group of characteristics or symptoms that come together to help define major depressive disorder. So anyway, it's a psychological or behavioral syndrome associated with distress. If you're having panic attacks, if you're having depression, if you're psychotic and can't distinguish between reality and non-reality, you're distressed, and the distress, present distress, is a key characteristic helping define abnormality. Disability has to do with impairment. This is essentially saying that the problems that you're having, the panic attacks, the depression, the post-traumatic stress reactions, are causing impairment, and they're affecting your functioning. Obsessive compulsive disorder, the person cannot get ready to go to work because they take too long showering or cleaning, or the ritualistic behavior, and it eventually impacts their functioning. Phobias, a flight phobia, you can't, if you're a professional football player, you can't travel on an airplane between Florida and Seattle. So then the last category, the significantly increased risk of suffering death, disability, or loss of freedom. This is applied more to a category called personality disorders or psychotic disorders. The lady is bipolar, and a psychotic thinks she's a saint and can jump off the Mack Bridge into the Ohio River, and she'll be able to walk on water. Clearly, if she tried this, it would backfire. If you have a personality disorder and you break the law or exploit others, eventually you run into the law and you get incarcerated. Or if you're alcoholic and have multiple DUIs, you'll run into the law and be in jail, or be the focus of civil lawsuit. So the second major category here, conditions excluded from consideration, I mentioned before, and in particular if it's an expectable or culturally sanctioned response. If you're depressed because your child died, they're not going to give you a diagnosis of depression, major depressive disorder. Or if you have deviant behavior, if you're politically atypical, or you have an unusual religion, or if you're a sexual minority, meaning you like to, maybe you're swingers or wife and husband swappers, or you're into consensual sadomasochism. If it's a sexual minority, then it could be excluded if it doesn't cause a problem. And also then conflicts between the individual and society. If you're eccentric and do strange things, but that's not enough. That excludes you from a diagnosis. Just being different is not enough to get a mental disorder diagnosis. So here's a chart of this. Generally, you have patterns of thoughts or behaviors. They can create distress, impairment, or risk of harm. And if you see this and they meet the DSM criteria, and they meet the DSM criteria, then you get a diagnosis and you have officially a mental disorder according to DSM. So notice here under this is that you don't need all of these distress, impairment, or risk of harm present to get the diagnosis. One or two may be enough to warrant a diagnosis. Here's a concrete example of a DSM diagnostic criteria. In this case, it's panic attack. Actually, panic disorder. Panic attack helps define panic disorder, but the criteria essentially, if you have a panic attack and there's 3 or 4 of them, then you get the panic disorder diagnosis. But in particular here, that this panic attack gets defined as a discrete period of intense fear or discomfort with at least 4 symptoms. It develops abruptly and reaches a peak within 10 minutes. It turns out that a panic attack resembles very closely a heart attack. So a lot of people who have a heart attack or have a panic attack believe they're having a heart attack, and the symptoms are very similar. So essentially, to qualify, the DSM says you have to have 4 of these specific symptoms at least to get classified as having had a panic attack, and then it turns out that there's specific criteria for panic disorder, which means that you have to have had 3 or 4 of these in a month's period of time. Here we go. This is the specific criteria for panic disorder. You have to have recurrent and unexpected, they have to come out of the blue, panic attacks. At least one of these has to be followed by 1 month or more of one of the following. So you have to have persistent concerns about having another one. You be obsessed or worry about it all the time, or you worry about the implications of the attack, or you have a significant change in behavior. So, for example, if you have a panic attack in your office and you never come back to work, which happened to a client that I'm familiar with, or if you're just obsessed all the time about going mentally ill or having a heart attack or things like this. So that would meet this criteria here. In this case, a lot of people that have panic attacks develop agoraphobia. They stay at home, they seek a secure situation. So, but if you don't have that, then you get the specific diagnosis of panic disorder without agoraphobia, then you have to have the absence of agoraphobia. Now here's an exclusion criteria for this disorder. The attacks are not due to physiological effects of a substance. For example, I worked in an anxiety disorder clinic for a while, and we would always ask in doing a primary assessment whether the person consumed a lot of caffeine. So if you drink, 24 cups of coffee a day and then have, if you're all wired up and have panic attacks, you may not have panic disorder, you may have something else, caffeine problem. And if the panic attacks are not better accounted for or part of another disorder, this is often referred to as differential diagnosis. For example, if you have a social phobia, in the context you're afraid of social situations and have panic attacks, in that context, then you would get diagnosed with a social phobia rather than panic disorder. The same for all the rest of these here that are listed. So panic attacks can occur, for example, in a variety of disorders. If you have something else going on and the panic attack is secondary to that, you don't get a diagnosis of panic disorder. Mr. Second edition, which I purchased for about $3, and it was about a ½ inch thick. The current DSM now is cost you $150, and it's about 1.5 inches thick. So, okay, I'm going to stop here. Thank you.